all the consultants and everybody else involved in drawing up a very detailed strategy which has everybody on board, I'm glad to say. I'm delighted to say that this will probably form the template of how small hospitals work in the future and will allow for a future for them, because up to now we've been worrying about the future of all our small hospitals. Most importantly, what this will do is see better service to the patient, shorter waiting times, and freeing up emergency surgery wards for emergency situations where, of course, they require specialist care. I would particularly like to thank the Regional Director of Operations in the HSE South for his tireless work in ensuring that the Minister's aims are being delivered on the ground. We need to move forward towards greater accountability and transparency in our health care delivery, and Minister Riley has succeeded in reducing waiting times and in reducing trolley times, and individual performances across the HSE should be monitored and be accessible for all. For instance, if there are 3 surgeons involved in the same procedure, the waiting times for each surgeon should be available online so that the patient can decide which surgeon they should go to. Also, in the case of prescription drugs, there should be a list of drugs prescribed, especially by the GPs, taking into account those who prescribe cost-effective generics in preference to high-cost brands, in order to generate best value for the patient. We also need to move to a system where prices of drugs are online, so that patients who pay for their drugs with minimal subvention have access to that information that will allow them to get their best value for money. I would also like to congratulate the Minister on the establishment of the Medicines Management Programme, which concerns the spend on medicines.
Deputy Barry, you have 1 minute.
Thank you. And he is tackling this in a substantial way, where in this Medicines Management Programme, the cost of medicines will be evaluated on their safety, their efficacy, their access to medicines, of course, savings for the state, and savings for the patient. This is a really holistic way of doing it, and it's a broader remit than ever before. It's coordinated between the National Pharmacoeconomics Centre and the National Medicines Information Centre, tying in, of course, with the collaboration of the HSE under the Primary Care Reimbursement Services. In private business, getting policies delivered is always important, and in small businesses it's done quite quickly, getting your policy right down to being implemented by the executive. But doing that in a large organisation is a very, very difficult task, and to deliver that change, takes time. And finally, I would like to congratulate the Minister as well on the establishment of the National Early Warning Score. And all these initiatives, which may sound like more jargon, but actually are well thought through, will deliver for the patient and in time will also bring us cost savings. Thank you very much.
Thanks, Deputy Joe O'Reilly, and the Deputy has 10 minutes.
Thank you, Cathaoirleach. I am delighted to welcome the introduction of this bill to the House, and in doing so, to state that the ongoing need for reform, for reorganisation, for refinement of services and improvement of services, and ultimately for the patient, nowhere reflects on the professionalism, the commitment and the wonderful work done by individual HSE employees at all levels over recent years. And there's no implicit criticism of their professionalism in the legislation or in the objectives of the legislation. They rather look at structure and at future direction and the ambition to deliver a single-tier health service. The government is 2 years in office today, and today marks its 2nd anniversary. And in that context, I would like to salute and compliment the achievements of Minister Riley and his department over those 2 years. They have successfully radically overhauled the health department. Since 2011, Minister Dr. Riley and his department has cut the cost of medicine by 400 million. That's a very significant achievement. They have allocated a further 35 million towards our mental health services and filled 246 new mental health posts. Another great achievement by the Minister and his department. They've also established a special delivery unit to work with hospitals, reducing the number of patients on trolleys and waiting times. In 2012, there were 23.6% less patients waiting on trolleys. It may not be where we would wish to be, but it's a true reflection of the fact and a real tangible evidence that we're going in the right direction, and it means a lot to those people affected, and it's a great achievement in the context of very stringent economic times. The Minister has achieved so much with absolute budgetary constraints. A 98% decrease in the number of adults having to wait more than 9 months for inpatient and day care surgery, and a 95% decrease for children. In Cavan General Hospital, I am pleased to report that the number of patients waiting on procedures has fallen by 48%, a very significant development. A new 34-bed cystic fibrosis unit was opened in St Vincent's Hospital. We've established a site for the Children's Hospital. So the bill that's been brought forward today is brought forward against that backdrop of real reform, real achievement, tangible differences for people. And the ambition of the bill is to continue that reform and build on it. There are two essential objectives of the bill. One is to make the HSE more accountable to the Minister for Health, and the other is to restructure the HSE in line with the Programme for Government Commitments, and specifically the move towards universal health insurance. Looking at number one, the bill is a transitional measure, and its intent is to implement the proposals as set out in the Programme for Government. It aims to ensure that there is more accountability between the Department and the HSE. More importantly, it will ensure that there is that there is a definite link, a greater accountability and involvement by the Department of Health and ultimately by the Minister, who is answerable to the electorate. And this is an important component of the legislation. The Minister has already started a process of change in this way. In 2011, he made changes to the composition of the HSE board, ensuring that there was a greater coordination and a higher level of dialogue between the senior officials in the department and the HSE. I suppose the fundamental flaw of the HSE as introduced in 2004-2005 was that it was imposed on an existing health board structure. So you were putting one new structure on another, and that it didn't have a sufficient linkage to the greater resource that is the Department of Health. And that was a fundamental difficulty that emerged and became an issue in a number of ways over the years. Minister Riley refers to this as unity of purpose, and the changes that he has already have guaranteed that there is a higher level of integration between the department, his department and the HSE. The bill will seek to eventually dissolve the current board structure and establish a new arrangement of governance. The bill will still have operational responsibility, or the HSE rather will have operational responsibility in the interim, but the accountability is strengthened. The second objective is to dissolve the HSE and move towards universal health insurance. The new HSE structure will have directorates and a Director General, and there's a flexibility about the number of directors in that a minimum of 3, maximum of 7, to allow for adaptability and allow for response to pertaining circumstances. And again, the Directorate will also be fully accountable to the Minister, and that's important. The Minister may issue directions to the HSE and the Directorate regarding the implementation of government policies relating to specific areas of priority, and that's important. Section 10 refers to levelling the balance of power between the Minister and government policy and the HSE's operational responsibility. Quoting the Minister, the HSE has a responsibility under the Health Act 2004 for the provision of health and personal social services. However, the HSE also has a statutory obligation to have regard to ministerial and government policies and objectives when performing its functions. And the new structures are intended, and the bill is intended to strengthen that process and that inherent thing. So the bill is only an element in a reform process. It's moving towards a single-tier health system whereby access to health care and the quality of healthcare will be the same and will be available to everyone irrespective of means, and that's what should be the objective. I want to make a reference to one or two specific areas within health policies as the kind of latitude we have at second stage allows. I'm delighted with the developments in primary care, and indeed both myself and my colleague Deputy O'Callaghan, who will be speaking later, would be aware of a number of recent openings of new healthcare centres in our area, in Baileybury, in Cootehill, and in Cavan Town. And the primary healthcare centres and there's one pending in Kingscourt. The primary, it's already functioning, but the opening is pending and it's going into full development stages. But the primary healthcare centres, in my view, have an enormous potential to have people treated effectively at home and have people where they want to be, close within their own home, within their own community, and have treatment brought to them. And I would say to the Minister, and I'd be very concerned about this, that we should be very careful to manage our home health services in a way that we maintain. I think the home health service is an enormous resource with enormous potential to augment the primary care service and to keep people within their own home. And I think dovetail with this is the carers allowance, which I know is the direct responsibility of the Minister for Social Protection. But the carers allowance, I think, has great potential to have people looked after at home. And I think it should be made more attractive. It should be made easier to access. It should be advertised more. It should be recommended more. And I think for people in particularly people in lower paid occupations who have relatives sick, it could become very attractive to become full-time carers if the carers allowance was a bit more attractive, more readily accessed. And I know there are inherent advantages in it already, but it could even be improved more. But I would say to the Minister that both his department and the Department of Social Protection should look at the carers allowance as a vehicle to achieve more in keeping people at home, in reducing institutional care, ultimately reducing costs, and providing a care to people where they prefer to be, which is at home. I believe we need to be very careful, and I'd be saying to the Minister that we should not reduce home health hours where possible. It's reasonable to redistribute them. It's reasonable to look at their allocation. It's reasonable to see that they're targeted on need. But it is not a good proposition to reduce them in absolute terms, and in fact it's increasing them. We should be on the premise, because it's through the provision of home health and the use of the carer and the home care packages that we will reduce institutional costs, make patients happier, let them be within their own home. And that's why I salute this. I would join with Deputy Neville in conclusion, Can Corley, in asking the Minister to elucidate, because I think the 35 million extra for the mental health services for that area is wonderful news. I would ask him to elucidate what plans are to have it spent quickly and immediately to implement the vision for change and to get community services developed there, because I think that's very, very important. And I would look forward to the Minister's response there. Thank you.
Thank you. I now call on the Minister to reply.
Gurmagad Ceann Comhairle agus gan buchas leis na teachtaí gcuireánaíochtaí leis an disport seo. I thank the deputies for their contributions to the debate. Mar solas de teachtaí tá an bille mar chuid de chóteachas níos leithne. Tá an rialtas ag tabhairt faoi chlár á chóirithe mór an gcóras sláinte agus é mar aim córas sláinte sreathamháin a chur fáil le tacaíd ón Oireachtas sláinte íleach. Áit a bhfuil reachtán bunathe Oireachtas ní ar income. Cadim gúil an bille seo ina chéim an móthar a chóirithe sin. Tá gá chos bór ige. As deputies are aware, this bill is part of a wider context. The government is embarking on a major reform programme for the health system, the aim of which is to deliver a single-tier health system supported by universal health insurance, where access is based on need, not on income. I believe this bill is a step on the health reform road. Its purpose is twofold. Géad dul síos forálin sé de dhearr an structure board HSE agus le haghaidh stúrthóireach a bheith an cólacht nua rialta don HSE in ionad ag an mór faoi ceannas ardstúrthóir. An dara dul síos forálin sé de sucrathe freagrachta breise don HSE. Tá sé thart acóirí chun deireadh a chur leis an gcóras gáisre chun é a dhéanamh othair lánach agus beag na torthaí is a chunéal d'othair mar thosaíocht I ngach a dhéanamid. So first of all, it provides for the abolition of the board structure of the HSE and for a directorate to be the new governing body for the HSE in place of the board, headed by a Director General. Secondly, it provides for further accountability arrangements for the HSE. It is about reform to end the two-tier system, to make it patient-centred, and it will keep outcomes for patients as its priority in all we do. Tá dul chun cinn sun tásach fethe gin hana féin, bunaigh an téanad seachar speisialta I mí iúil fethe éondeag. Ag an am sin, de bhí 2017 is trochadó othair ag fanacht níos mó ná bliain, agus 6,277 othair ag fanacht níos mó ná 9 choiríle chunaí nó choiríle lé. We've already seen significant progress. The Special Delivery Unit was formed in July 2011. At that time, 2,732 patients were waiting more than a year, and 6,277 patients were waiting more than 9 months for inpatient or day case treatment. Faoi nullag fethe a héideag, bhí tíim thugtha líon na daoine fásta ag fanacht níos mó ná 9 le haghaidh chorála chunaí nó chorála lé. Go 3,700 is sé, ar séir, agus bhí deire bhí na nullag fethe dóag bhí an líon céine ag 86. Léiríonn sé sin laidú de 8%. By December 2011, the number of adults waiting more than 9 months for inpatient or day case treatment had fallen to 3,706, and by the end of December 2012, the number was just 86. This represents a 98% decrease. I gás páistí is an spruch go chuir nach méid éon fáiste ag fanacht níos mó ná 27 do othair chunaí nó máinliachta othair lé. Bhí na nullag fethe dóag bhí an líon ag fanacht níos fada ná 27 go dtí 8 le titim den óca 5% an 1,700 is chuig an ípáistí ag feitheamh níos fada ná an spríc I mí na nullag fethe a héideag. So for children, the target is that no child should be waiting more than 20 weeks for inpatient or day case surgery. By December 2012, the number waiting longer than 20 weeks was down to 89, a drop of 95% on the 1,759 children waiting longer than the target in December of 2011. In the area of emergency departments, despite the winter pressures, including increases in flu and respiratory illnesses, the year-on-year improvements continue nationally. Numbers recorded on trolleys at the end of 2012 show a marked improvement of 23.6% less than in 2011, which equates to 20,342 less people lying on trolleys. Progress continues to be maintained in 2013. On Friday the 1st of March 2013, the numbers on trolleys on the year to date total 12,283, which is a reduction of 2,116 patients, or 14.7% on the improvements already made in 2012. We have much more to do, and we will continue to make that progress. If I turn again to the bill, the position is that this bill is about a new governance structure for the HSE and about increasing the HSE's accountability to the Minister for Health and ultimately to the Oireachtas and the people. Contrary to what has been suggested during the debate on the bill, it is not about the Minister for Health taking over the HSE's functions, nor does it give sweeping powers to the Minister. The HSE has responsibility for managing and delivering health services and that does not change under this bill. The Minister and the Government have responsibility for policy. Any state agency must have regard to the policies and objectives of the Government to the extent that those policies and objectives may affect or relate to its functions. A state agency must be accountable to the Minister concerned and therefore must explain its actions and decisions. The Health Act 2004 and this bill provides for this accountability. The Board of the HSE is the current governing body of the HSE. The abolition of the board's structure and the increased accountability measures are intended to help prepare the service delivery and funding systems for the next phase of the reform programme. As the HSE board structure is to be abolished, it is necessary to replace the board with an alternative governing entity. The proposal in the bill is to have a directorate as the governing body, comprising the Director General and senior employees. The Directorate will have collective responsibility as the governing authority for the HSE. Issues were raised in the debate about the detailed governance mechanisms and interrelationships for the Directorate members under the bill. In practice, the Directorate model will involve a combination of a senior management team working together on major corporate issues, but with the usual operation line of reporting for the specific service functions. Deputies asked why members of the Directorate must be appointed from HSE employees. The establishment of the Directorate is about more direct accountability, whereby the governing body of the HSE is drawn from people in senior positions within the organisation itself. I should clarify that this means that appointed directors are not limited to current employees, but may be drawn from HSE employees, irrespective of when the employee was appointed. There will be new administrative structures in the HSE which, while in support of the bill, are separate from it. The HSE has begun the process of putting in place the new administrative management team. The recruitment process for 5 new national directors has now commenced through a competitive process to be run by the Public Appointments Service. One of the new posts is Director of Mental Health. Deputies asked if there could be specific reference to a Director of Mental Health with specific functions in the bill. While I am very glad to say that the Director of Mental Health post is one of the posts included in the competitive recruitment process I mentioned, I do not believe that the legislation should specify the functions of particular grades within the HSE. The appointment of the first Director General was raised. There are legislative precedents providing that the first person appointed to a new office to be appointed as envisaged under the bill, and this seems to me to be the most practical way to advance the new governance arrangements. The bill against Corla is a transitional measure and is part of a much larger plan. I said at the beginning that the government is committed to fundamental reform of the healthcare system with the objective of delivering a single-tier health system supported by universal health insurance, where access is based on need, not on ability to pay. Deputies have asked me to clearly state my plans in relation to the changes that are coming for the health system. In November 2012, myself, my colleagues Minister Kathleen Lynch and Minister Alex White published Future Health, a strategic framework for reform of the health service 2012 to 2015. Future Health sets out the major healthcare reforms that will be introduced in the coming years as key building blocks towards the introduction of universal health insurance. I intend that further detailed actions will be built on the foundations of Future Health as the reform process proceeds. I have identified an overall governance structure for the programme of reform. The new structure includes a strong programme management office in the Department of Health to drive and oversee implementation of the health service reform programme in line with the public service agenda, and a systems reform unit in the HSE. The Government recognises that effective consultation and collaboration with stakeholders will be crucial for the successful implementation of the reform programme. In the 2 weeks following the launch of Future Health, I met with some 1,500 local clinical and administrative staff and management, as well as regional health forums at 14 different events across the 4 HSE regions. Consultation will continue throughout the reform process. The progress to date underlines this Government's commitment to health service reform and the implementation of universal health insurance. We are confident that with the involvement and support of all the main stakeholders in the health system, we can deliver on our objectives in the best interests of patients. Deputies asked about universal health insurance. Preparation is key to universal health insurance, and the new governance arrangements for HSC under the bill are intended to play a part in preparing the system. Under UHI, every individual will have equal access to a standard package of primary and acute hospital services, including acute mental health services. A new insurance fund will subsidise or pay insurance premia for those who qualify for a subsidy. There are a number of important stepping stones that are necessary to pave the way for the introduction of UHI. Work is currently underway to advance these initiatives, which will bring benefits and drive efficiencies in advance of implementing universal health insurance. These include the strengthening of primary care services to deliver universal primary care with the removal of cost as a barrier to access for patients. The work of the Special Delivery Unit in tackling waiting times and establishing hospital groups, and the introduction of a more transparent and efficient money follows the patient funding mechanism for hospitals. An important point is that in February 2012, I established an implementation group on universal health insurance to assist in developing detailed and costed implementation proposals for universal health insurance and in driving the implementation of various elements of the reform programme. We must learn from other countries and build on best international experience. This is reflected in the membership of the Universal Health Implementation Group. The UHI Implementation Group comprises a mix of those with executive responsibilities within our health services and external expertise, including international experts working with the World Health Organization and the European Observatory on Health Systems and Policies. In addition, my officials have been examining the experience of health reforms in a range of countries, including the Netherlands and Germany. This analysis is vital to enhancing our knowledge and informing policy. However, a prerequisite for designing the UHI model for Ireland is that it meets the needs of individuals here in Ireland and that it achieves the best outcomes for patients here. This requires that we have regard to our starting point, that we carefully plan and sequence the reform programme, and that we give detailed consideration to the most appropriate structures for delivery of different services. Ultimately, the Government is committed to introducing an Irish model of universal health insurance that best fits the Irish system. The Department is advancing work on drafting the White Paper on Universal Health Insurance, which will outline details of the UHI model, in addition to the estimated costs and financing mechanisms associated with the introduction of universal health insurance. Preparation of the White Paper is a complex and technical process requiring significant research and financial modelling to support analysis and costing of different design options. My department is engaged in a process to ensure availability of the necessary expertise to support work on preparing the White Paper in 2013. In the meantime, and in advance of the White Paper, my department published a preliminary paper on UHI. That paper provides a succinct update on work in relation to universal health insurance, as well as providing further details on the path ahead. The reform programme is a major undertaking that requires careful planning and sequencing over a number of years. The implementation group will assist, advise on and oversee different elements of the reforms as they're being put in place. It is also my intention to consult widely as part of the reform implementation process. Several deputies referred to medical cards and in particular individuals with very serious health conditions. First, let me say again that more than 1.8 million medical cards have been issued to individuals today. This is the highest percentage of the population covered in the history of the state. Medical cards are provided to persons who, under the provisions of the Health Act 1970, are, in the opinion of the HSE, unable, without undue hardship, to arrange GP services for themselves and their dependents. Under the legislation, determination of eligibility for a medical card is the responsibility of the HSE. The assessment for a medical card is determined primarily by reference to the means, including the income and expenditure of the applicant and his or her partner and dependents. Under the legislation, there is no automatic entitlement to a medical card for persons with a specific illness such as cancer. There is, however, a provision for discretion by the HSE to grant a card in cases of undue hardship where the income guidelines are exceeded. The HSE set up a clinical panel to assist in the processing of applications for discretionary medical cards where there are difficult personal circumstances. Most importantly, the HSE has an effective system in place in relation to the provision of emergency medical cards for patients who are terminally ill or who are seriously ill and in urgent need of medical care that they cannot afford. Emergency medical cards are issued within 24 hours of receipt of the required patient details and the letter of confirmation of the condition from a doctor or medical consultant. This can be initiated through the local health office by the office manager, who has access to a dedicated fax and email contact with the Primary Care Reimbursement Service, the PCRS. Whilst it can take a day to physically produce the plastic card and a further day to allow for its arrival in the post, the medical card number can be provided to the local office or social worker within 24 hours if requested. Once approved, any primary care contractor can validate the entitlement of a client through the online system. With the exception of terminally ill patients, the HSE issues all emergency cards on the basis that the patient is eligible for a medical card on the basis of means or undue hardship, and that the applicant will follow up with a full application within a number of weeks of receiving the emergency card. As a result, emergency medical cards are issued to a named individual with a limited eligibility period of 6 months. The arrangement is slightly different for persons with terminal illness. No means test applies to an application by a terminally ill patient. Once the terminal illness is verified, patients are given an emergency medical card for 6 months. Given the nature and urgency of the issue, the HSE has appropriate escalation routes to ensure that the person gets the card as quickly as possible. Deputies have mentioned the backlog of medical cards. I'm happy to say that the major backlog of last year has been cleared. Furthermore, in relation to discretionary medical cards, there was a backlog toward the end of last year, and that has been reduced from 3,500 to just 9 cases today. And contrary to some of the contributions and common belief, the centralisation of medical cards has resulted in an 8 million saving to date. So I think the PCRS can be commended for the work that they have done to address the issues of backlogs and indeed by bringing in a more efficient system. The issue of free GP care has also been raised. The bill to allow for the extension of free GP care to persons with prescribed illnesses will be published early this year, in the next couple of weeks, I hope. Progress also continues to be made in building primary care capacity and in chronic disease management, particularly for the management of diabetes, which will commence in the coming months. Some deputies asked what I was doing to address the cost of health insurance. I can assure the House that the Government is committed to keeping down the cost of health insurance so that it is affordable for as many people as possible. We are committed to protecting community rating, whereby everyone pays the same price for the same health insurance product, irrespective of age or health status. The programme for government contains a commitment to put a permanent scheme of risk equalisation in place, which is a key requirement for the existing private health insurance market and is designed to keep health insurance affordable for older persons and to maintain the stability of the market. The Health Insurance Amendment Act 2012 gave effect to a new risk equalisation scheme with effect on the 1st of January 2013. This will contribute to the protection of affordability for those who need it most. It is important to note that the measures contained in the new risk equalisation scheme are designed to result in no overall increase of premiums paid in the market. Rather, it is intended to spread the risk more evenly between the healthy and the less healthy, as well as the old and the young. I have repeatedly raised the issue of costs with health insurers as a whole, and I am determined to address costs in this sector in the interests of consumers. Last year, I established a Health Insurance Consultative Forum, which comprises representatives from the country's main health insurance companies, the Health Insurance Authority and the Department of Health. The forum was established to generate ideas which would help address health insurance costs, whilst always respecting the requirements of competition law. Given the VHI's very significant share of overall costs in the market at 80%, I will continue to focus strongly on the need for the VHI to address its costs and to address aggressively the base costs of procedures, including professional fees, and also that there would be more robust auditing, and indeed that for the first time clinical auditing would be introduced. In other words, that the treatments that some clinicians are delivering would be challenged as to their necessity. The issue of delays in replies to PQs was commented on by many deputies. I'm happy to provide some detailed information. My department received over 7,500 parliamentary questions in 2012. 4,045 of these concerned operational issues and were referred to the HSE for direct reply to the deputies. In its service plan, the Executive has a commitment to answer 75% of PQs referred to it within 15 working days. Of the 4,045 referred to it for direct reply, 74% were answered within 15 working days and 83% within 20 working days. This represented a significant improvement on 2011, when the percentage answered within 15 days was 56%. Of the total amount of PQs referred to us in 2012, only 64 remained open at the end of the year. We want to improve further on this by examining IT solutions that would help TDs and senators to track the progress of their PQs. Procurement issues were also raised in the debate. The HSE is fully committed to the government's procurement objectives and initiatives and will continue to support the government programme to reform public sector procurement. Adherence to the government public service reform objectives regarding the use of shared services will be a requirement for the newly created structures in relation to procurement and other matters. The Director General Designate of the HSE has acknowledged that the new governance and management arrangements for the future health service will require us to radically change the way we approach the provision of shared or common services to meet the needs of all parts of the health system. In addition, the financial challenges we face mean that we must take advantage of any opportunity for increased value in the way we provide such services. And as this day marks 2 years in government, I have mentioned some of the progress that's been made, but I might just mention some other areas. In relation to outpatients, there's clear and comprehensive data now being reported for the first time, which will allow the SDU and the National Treatment Purchase to target resources at the longest waiting lists. There are new cystic fibrosis services in the Nutley wing of St Vincent's Hospital, which opened in summer of 2012 at a cost of almost 30 million. There's a decision to co-locate the new Children's Hospital at St James's, made in November 2012. We have 35 locations for primary care centres have been identified, of which 20 will be commissioned, subject to the agreement between local GPs and HSE on active local GP involvement and site suitability and availability. In October 2012, a new drug pricing agreement was reached with the Irish Pharmaceutical Healthcare Association, which will deliver savings in excess of 400 million over a 3-year period. About half of its value, 210 million, will be used to cover the cost of new drugs from 2013 to 2015. The balance will go towards reducing expenditure on drugs supplied through the GMS and community drug schemes. The Department and HSE have also reached an agreement with the Association of Pharmaceutical Manufacturers in Ireland, which will deliver further savings in the cost of generic drugs. And total gross savings between the IFA and APMI agreements for 2013 will be in the region of 120 million. There is also our drug reference pricing bill, which is coming back to the House shortly. Going to committee actually this week or early next week, and that will allow us, after consultation, to set the price for generic drugs. And we have a new medicine management initiatives, as has been outlined by Deputy Barry. The HSE's healthcare capital allocation for the period 2012-2016 is 1,870 million, of which 1.67 billion is allocated for construction of healthcare facilities, and the remaining 200 million is allocated to ICT infrastructure. And in addition, the government announced in November 2011 that up to 200 million from the proceeds of the sale of the National Lottery would be allocated for the construction of the new Children's Hospital. We've also appointed a chair to the new Children's Hospital Group. We will be opening new facilities, a new wing at Ennis Hospital. The new emergency department at Letterkenny is finished and will be opened later this year officially. The outpatients and emergency department at the Mater Hospital are completed, and we are making progress with the new Central Mental Hospital. Value for money and policy review of disability services in Ireland was published on the 20th of July 2012. The National Housing Strategy for People with Disability 2011 to 2016 was approved by the Government in October 2011, and the implementation framework jointly published with the Department of Environment, Community and Local Affairs in July of 2012. The Children, Adolescents and Young People with Complex Disability Unit is led by a principal officer, and that has been established in the Department of Health. And on January the 1st of this year, a permanent scheme of risk equalisation was put in place in the private health insurance market. Last December, the Government approved the implementation of the judgment of the European Court of Human Rights in the ABC versus Ireland case by way of legislation with regulations with the parameters of Article 43.3 of the Constitution as interpreted by the Supreme Court in the X case. And progress has been made towards heads of bill there. So there's many other areas in relation to older people, health and well-being, health protection, mental health, which others asked about, and the 35 million that has been earmarked for that, the increase in the number of beds for adolescent psychiatry, the issues around the drug task forces and HR and health reform, as I've outlined. So there's been a lot of improvement. Another issues that I just mentioned very quickly, the long-running problem at Tala Hospital Board was resolved. Hospital groups have been set up in Galway and in Limerick with a phenomenal effect in Galway in particular. Clinical programs are moving ahead. We've developed them in emergency medicine, in acute medicine, in the fragile older patient, in stroke care and heart failure. And we have also, for the first time anywhere in the world that we're aware of, introduced a new early warning scorecard so that doctors and nurses will in Tralee react the same way as they will in Letterkenny or the Mater or St James's in the face of a patient who may be deteriorating. And the screening for bowel cancer has commenced. So we do continue our commitment to reform, and I'll just say in finishing that they will continue unabated. And I will not be deflected from the course that we have set. I remain determined, as the government does, to see this through. I am as committed as ever to it, and I'm more certain and convinced than ever that we will succeed because of the new leadership emerging in the HSE, the Department of Health, and indeed the VHI. But most importantly is the new leadership that has emerged amongst the clinicians, medical, nursing and allied professionals, the men and women on the front line who have already delivered so much for us in the terms of the improvements that I set out earlier. So, Mullen and Bill Dunchach,
Good morning. Is that agreed? Second stage, second stage agreed? Not agreed. Glefer and Bill on Dara or Anish, na Jackie atá héib na Keshta Abadish tá, na Jackie atá na Kena Abadish Neil, Sheelam Gun and Kesh Richard. Thank you. Item number 28, Health Service Executive Governance Bill 2012, second stage. The question is that the bill be now read a second time, and on that question a division has been challenged. Tellers Tall Deputies Paul Keogh and Emmett Stagg. Tellers Deal Deputy Sean O'Farrell, August Jonathan O'Brien. To 89, Neil 43. The bill is past the second stage. I understand it's proposed to refer this bill to the Select Subcommittee on Health. Does the Minister wish to move the motion of referral now? Is that agreed? Agreed. Before moving on to the next business, I wish to inform the House that Seanad Éireann has passed the Finance Local Property Tax Amendment Bill 2013 without amendment. Now, when you're ready. The Defence Forces Second World War Amnesty and Immunity Bill. When you're ready, we're now moving on to the Defence Forces Second World War Amnesty and Immunity Bill 2012, Seanad, second stage. Minister to move the second stage, that the bill be now read a second time.
Thanks. Ken Corley. I'm pleased to present the Defence Forces Amnesty and Immunity Bill 2012 to Dáil Éireann. When this bill was originally published last December, Minister Shatter said that he hoped that through the actions proposed in the bill that it could help put the rest of the concerns of these individuals still alive, who fought for freedom against tyranny with Allied forces during the Second World War. He also expressed the view that the bill might lift the veil for the families of those who have already died. Having had the honour of taking the committee and reporting stages of the